Bye. Hey everybody, welcome to Knock Knock Eye with me, your host, Dr. Glockenflecken, your one-stop shop for all things eyeball related. And for those of you who are return listeners, you've been watching and listening to these eyeball episodes that I've been doing over the past year plus. Tell me something you've learned about eyeballs. Something you tell your friends, something that you tell at dinner parties before you realize that what you just told them probably makes you not be invited next time. I want to know what are the things that you regale your guests with as far as eyeball tips and tricks and factoids and things that you've learned from me. And if I don't get any responses, I'm just going to assume that you just forgot. And it's not that you don't remember anything I tell you. You just, have a short-term memory. And that's fine. I have short-term memory loss around my cardiac arrest still. There's lots of things I don't remember. And I rely on Kristen to inform me. No, actually, that's not the way things were. And I'm pretty good now though. I feel like, I don't have a lot of age related short-term memory loss, if that's a thing. I don't know. Kristen swears it is because she forgets things all the time, but maybe that's just a personality thing. Anyway, thank you for being here. I'm excited. I've got a fun episode for us. We're going to talk about a few things here off the bat. I'm getting into some Q&A, and we're going to talk retinal tears. We're going to talk flashes and floaters, retinal detachments, retina. I've done some of this stuff in the past in various ways. And so, I'm going to start getting into a few repeat topics because a lot of people have found this podcast, found these Knock Knock Eye episodes more recently. And so, it's if it's been a year or so, I might, rehash some stuff because take it from me, someone who's been through medical school, repetition is key to learning things about anything. And so definitely when it comes to ophthalmology. All right. So first of all, I just want to go through some of the things that's coming up on my schedule. I have a couple things to talk about. Later this month in September, I'm going to be going to the American Association of Pediatrics, the AAP. I'm giving a keynote to the AAP. I'm so excited. Some of my favorite audiences are pediatricians. And I'll tell you why, because they always come wearing the headbands. You love the headband, the unicorn headbands. It's great. You're handing out stickers. It's such a fun environment. Some of the loudest laughs and roars that I've received during a keynote over the years has been pediatric audiences. I don't know. You're just ready to have fun. You're ready to learn. You're ready to do things that help kids. And that is infectious. That makes me excited to do what I do. I don't know. It just that kind of enthusiasm just rubs off on me. I love it. I love those pediatrician audiences. I honestly, what a great profession. It really is. Like you go on social media and you have people, obviously there's a lot of turmoil right now in the world of pediatrics, and which is something I'll probably be talking about, from what I know and have gleaned from interactions in my life and on social media. Clearly, with the RFK stuff, the loss of Medicaid funding, the Trump administration doing things to undermine pediatricians. It's been a challenging year, to say the least, for our pediatrician colleagues out there, and for kids. And so I think people are going to be coming into this conference with a pretty low morale. And this conference will be an opportunity to be with their colleagues, commiserate with their colleagues, also have some fun. And I'll be there hopefully to be a little bit uplifting, to try to remind people why they do, the impact that they're having on their patients. But this is probably one of the more challenging keynotes that I've given, just as I'm thinking about what to say, how to approach certain topics. I don't know. It's going to be tough. I'm excited about it. I can't wait. This is the earliest I've actually thought about my keynote. Like I've been thinking about it for like a couple months now. Like, what am I going to say to these pediatricians? So it's a fun thing to solve, right? Like how do I get the most impact out of this talk? I'm so thrilled to be there with the wonderful pediatricians out there. But one thing that keeps sticking with me, that I wanted to tell you all in this episode is just what, we talked to a congressperson on the podcast, God, probably like 2 years ago now, and it was Katie Porter, and what she said really stuck with me. And we were talking about, how all of these Congress people, these representatives, senators, they have every year, throughout the year, they'll have doctor groups that come to them with an ask, right? They'll have all these meetings, people that want something from them. And almost universally for physician groups, physician advocacy groups, whether it's like the big surgeon lobby or the ophthalmology lobby or radiologist, whatever specialty it is, that group that comes in and advocates, the top of their list almost universally is increasing reimbursement. They want more reimbursement. And you can understand why. I'm not sitting here, I'm not telling you this because that's a bad thing to advocate for. It's a totally reasonable thing to advocate for. Because our reimbursement does keep going down every year. So you do feel like as a physician group, you have to advocate for that to see if maybe you can make a dent in decreasing the percentage that your reimbursement goes down every year, because it does go down every year. So yeah, you can understand why but thinking about it from a representative standpoint, from a state or U.S. House of Representatives or the senators, you can understand how like it just starts going in one ear and out the other, because you're hearing the same thing from every single group over and over and over again. First thing out of their mouth with these meetings, what are we going to do about reimbursement? And so they get it kind of like just, deaf to it, right? They just don't, it's like, well, okay, great. Like anything else, but Katie Porter said something that still haven't forgotten. I still talk about it, that with pediatricians, it's different. They are noticeably different in that the top of their list, their advocacy list are things that really impact patient care, that are really trying to improve the life of children. And that's like gun safety, other safety measures, and Medicaid funding, these types of things. And so it's a stark difference from other specialty groups. And I think the rest of us can probably take a little message from that. Like, still advocate for increasing reimbursement, but maybe let's think about like what else we can do whenever we have our advocacy days on the Hill. Like what maybe something we can supplant that just for a year or two and be like, okay, well, hey, maybe we can do this. It'll maybe get the Senate's attention, get your senator's attention, and make them a little bit more engaged in helping a large group of people, namely patients. Right. So I never stop thinking about that. And it just speaks to who pediatricians are, right? Like they're, yeah, they want to get paid more, and they should get paid more. But it really does seem like that is secondary to their mission, why they became pediatricians. They seem, I guess, maybe less jaded, less certainly I'm sure they're burned out, but it's like they are more in tune to the overall reason why they got into medicine. They're more in tune to that years into their career than other physicians, if that makes sense. So I don't know. It just and that's one thing that just makes me so excited to go to Denver in a couple of weeks. By the time I think this comes out, well, it'll be like right before I go to Denver to talk. It makes me so excited to be talking to people that I know that everyone there is really engaged and ready to advocate on behalf of their patients and make life better for children. That's as a keynote speaker, as a comedian, as whatever the hell I am, I I love that type of audience. That is a fun. That's why I get so pumped when I know there's going to be like a lot of residents, a lot of med students in the crowd, even pre-meds, trainees, people early in their career, because they still have that feeling. Like, man, look how educated I am, and the power I have to try to change the world, to try to change healthcare and make it better. That enthusiasm, I can feel it. I give like 15 keynotes a year to different specialty groups. Like, I can feel when that's not there in how people react, how the crowds react to what I'm talking about. And I don't know, as I can't explain it better than that. And it does seem to correlate with how far along people are in their careers, with the exception of pediatricians. So shout out to pediatricians. Other things I'm doing. One other thing is I'm going to Stanford, and actually in just a few days, I'm going to their Big Ideas conference, where we talk about big ideas. I think AI is going to be one of those big ideas. But here, so I thought I'd just share with you all like what big ideas I'm bringing to Stanford. I don't know if they're really big ideas, but they're just ideas that I think are going to be really important going forward. One big idea that I'm just going to keep beating the drum on because it's really important to my family, to my personal lived experience, is the issue of co-survivorship. Uh, we talked about this with my cardiac arrest, where Kristen, Lady Glockenflecken, she is a co-survivor of medical trauma. She's a co-survivor of my cardiac arrest. She's a co-survivor of cancer, of my testicular cancer. She did not have those things happen to her in her body, to her body, but they did happen to her, right? She lived through those things, and has caught, and those types of things, doing CPR on a loved one has ramifications, physical and psychological ramifications. And we don't think about that. So that is a big idea that we have, that Kristen's done an amazing amount of work raising awareness of this idea of co-survivorship, because it's just not the way physicians think. We are focused on the patients because we have to be, and we often just overlook the people. I hesitate to use the word caregiver, but caregiver is a good word for a certain type, certain people, but it doesn't really encapsulate that trauma that you can experience when you're going through a major medical event, major diagnosis, treatment, death, uh, disability with a loved one. All right. You are a co-survivor of that medical trauma. So anyway, that's a big idea I'll be talking about with the people at the conference. And also just trying to put um, social media in perspective. We very easily lose this perspective that we think, because we are all on social media, that's where the vast majority of us, myself included, are getting our news. We are seeing reactions to the news from this generally a very small group of people. And we get the feeling like these opinions, these words, either good or bad, is representative of society, of our patients. And I just want to remind people, and this is what's like, is this a big idea? I don't know. That it's not the real world, right? Social media, it's important. Like, physicians need to be there refuting all this misinformation because people are getting their information there, but it's not real life. And so I think one big idea I have is, like, I think that we need to be uh, making our world as physicians a bit smaller. That sounds kind of weird, but as someone who has got a huge audience, but I think consuming all this social media and seeing all this negativity surrounding misinformation and the healthcare system, health insurance, private equity, all this stuff, it's like pouring gasoline on our burnout. And so I think it's going to be really important over the next decade for us to scale down, to try to block out that noise and focus on what's really important. And that is the physician-patient relationship. Really, like, just letting that be your driving force and not what somebody is saying on social media. Social media is important. We have to be there. I'm not saying don't use social media. I'm still going to use it. I'm still going to make my content, but I'm going to try to keep in perspective what really matters. Advocacy matters on the big scale, but all the opinions, all the bad news, all the things like that can be secondary, focusing in on what really matters, what's in front of you, what are you seeing with your eyeballs in person is that patient across the room. I think we need to be reminded of that, especially the young folks coming in, the med students, the residents, because all the social media stuff, it's very distracting. But focusing on of improving yourself and thereby improving that relationship you have with your patient is something we all need to be reminded about. All right, let's take a break. Hey, Kristen, it's September. You know what that means?
Yeah, my birthday.
It's also Sepsis Awareness Month.
That's true.
We need to talk about a podcast that every clinician should know about, the Sepsis Spectrum. It's hosted by clinical care educator Nicole Kupchik.
It's a good one.
It is. Each episode is about confronting blind spots in sepsis and antimicrobial resistance education. A lot of this stuff doesn't make it into textbooks.
Yeah, and it's super important.
Yeah, you can listen to the Sepsis Spectrum wherever you get your podcasts or watch it on Sepsis Alliance's YouTube channel. To learn about how you can earn free nursing CE credits just by listening, visit sepsispodcast.org. All right, let's do some comments. I haven't done any comments in a couple weeks, I think, or at least not very many. All right, we got some good ones on the most recent episode titled, Are My Arms Too Short or Is This Presbyopia? I got to hand it to my producers. They are the ones that do the thumbnails, which are photoshopped. Most of them are. And also the titles. Like they have to listen to me talk about eyeballs every week and then try to come up with some title that explains what I'm talking about. So this one was, Are My Arms Too Short or Is This Presbyopia? All right, so I had some great comments. I talked about a lot of different things in that episode, but here's a couple. At HH the Great, I had LASIK 20 years ago. There is only one ophthalmologist within 100 miles who will do cataract surgery on LASIK patients. I'm going to come back to that because that's kind of strange. Once I accepted that I'd have to make a trip to get it done, I started wondering whether or not to get the expensive intraocular lens. That's because you take out the cataract, you put the lens inside the eye. The expensive one that will fix astigmatism or near vision. Nope, no fancy lenses for you, LASIK patient. Is that a universal thing? This is a great question. I probably forgot to mention that when I was talking about cataract surgery. Is that this is a couple things are kind of like strange to me. First of all, only one ophthalmologist within 100 miles who will do cataract surgery on LASIK patients. So if you do cataract surgery, you should absolutely be doing cataract surgery on LASIK patients. Just because someone has had LASIK does not disqualify them from getting cataract surgery. Because everybody is going to get cataracts. So I don't care if you've had LASIK. I don't care if you've had RK, which is an outdated procedure that caused a lot of harm that we still do cataract surgery for. If you've had LASIK, you still get cataract surgery. So I don't know who these cataract surgeons are that are refusing to do cataract surgery on patients just because they had LASIK. But if you exist out there, I hope you're listening to this. In fact, patients, if you come across this, all of you listening, if you come across this, play this clip for that person. Shame on you. Shame on you, person, whoever you are. You call yourself a cataract surgeon. Not doing cataract surgery just because someone had LASIK. I get it. It makes it a little bit trickier to get the calculations to figure out what lens to put in the eye. But guess what? That's what they pay you the big bucks for. Okay, sir or madam. So do it. Do the hard work. It's not even hard. Get it done. All right. This person needs cataract surgery. This person who's showing you this video right now, they need cataract surgery. So do the cataract surgery. Do your job. Okay. Just do it. Do it. You're board certified. You have no excuse. All right. Now, here's the thing. The second part of this comment is, what type of lens can you get? So there's, as I mentioned before, there's multiple different artificial lenses you can get in your eye with cataract surgery. There's just the standard monofocal lens. So that lens you put in your eye, it has a power to it. It'll give you a one focal distance, one focal length, right? Usually we just estimate it as distance or near, one of those two. The second option would be something that also fixes your astigmatism. Not everybody qualifies for an astigmatism correcting lens, what we call a toric lens. If you don't have any astigmatism, then you don't need that. We don't even talk about it. But if you do have enough astigmatism, then that can actually it basically acts just like a monofocal lens. It is a monofocal lens, except it also has astigmatism correction. The third option is a multifocal lens. That's quote unquote the fancy lens. That's what's going to cost you $2,000 to $3,000, sometimes $4,000 to get these things. All right, they're very expensive, but they give you multiple focal lengths. So that is a lens that has little concentric rings in it that'll say, okay, it can get you a distance, it can get you computer, it can get you reading, all without the need for glasses. That's the selling point of these multifocal lenses. So when you've had LASIK, what does that disqualify you for? Well, when you have had LASIK, you can absolutely get the monofocal lens, the standard. You can absolutely get the astigmatism correcting lens, because that's also a monofocal lens, just one focal length. That doesn't complicate things, just adds astigmatism correction. You can definitely get one of those two. The tricky thing is that third option, the multifocal lens. So I personally, I do not put multifocal lenses in someone who has had LASIK, because LASIK, it changes the shape of your cornea. It can add what we call spherical aberration to your cornea. And when you put a multifocal lens in, I'm going to spare you some of the technical like physics details, but there's a combination of things that can make it to where you have more like halo around lights, kind of vision blur. It just the combination of LASIK and a multifocal lens, it just doesn't mesh well. Now, there are certain types of multifocal lenses that like have a little bit less multifocality, maybe not as much near vision, but like distance and computer vision. That might work okay, but still, you're running, when you put one of those lenses in your eye, you run the risk of having these basically vision irregularities. Will you be able to see okay? Yeah, but in certain conditions, bright lights coming at you, bright sunny days, you can still get lots of glare and halos that can affect the quality of your vision and your quality of life. So, as someone who does cataract surgery all day, once or twice a week, I will not put a multifocal lens in someone who has had LASIK. And I encourage you to think along the same lines. So if there's a lot of physicians out there, a lot of surgeons that will basically put those lenses in anybody. All right. But my criteria for a multifocal lens for cataract surgery is you have to have totally normal, healthy eyes. That means no prior surgeries. That means a normal cornea, no significant dry eye. You don't have glaucoma. You don't have macular degeneration. You don't have diabetic retinopathy. You have a normal, healthy, totally good eye. All right. That's the person I'll put a multifocal lens in. So great question. Thank you for that. All right, let's do a couple more. I love, this is a great comment. All right. I'm not going to read the whole thing because it's very long. But basically this is from @SeanP. Says, let me get this straight. Since I'm nearsighted, I need to, number one, go to the doctor. Number two, read letters of the alphabet from 20 feet away. Number three, sit still while I get a shot in the eye with air. By the way, only optometrists do that, not ophthalmologists. because historically optometrists were not allowed to administer numbing eye drops or any eye drops whatsoever. And so that's why they devised a method of testing eye pressure without putting a numbing drop in your eye. Enter the puff of air, pneumotonometry. So it's a relic. Only optometrists have that. Ophthalmologists, we don't do the puff of air. And then Sean here goes through 15 different things that basically the whole idea of that part of the comment is I have to go through all these things because I'm nearsighted to get a pair of glasses. And then he says, but when I get old and I'm going to need help seeing things closer, I just need to wander into a Hallmark store and buy a pair of $7 reading glasses. By the way, $7 might be a bit expensive. I think you can get a 10 count, a 10 pack of 2+ readers at Costco. But yeah, it's a good point though. Like why what's the difference? Why are sunglasses, why are a pair of glasses for nearsightedness, for myopia, all you poor myopic people, why do you have to pay so much for glasses? But when you're old and you just need reading glasses, you can just wander into Walgreens or Hallmark and get yourself a pair of over-the-counter readers. It just has to do with the complexity of the glasses. Whenever you're getting over-the-counter readers, they're just magnifying lenses. Just like you can go into any store, to Target, and go buy yourself a magnifying lens. That's all you're getting with readers. All they are, magnifying lenses. That's all readers are. And they have different powers. You can get stronger magnifying lenses or less strong magnifying lenses. They just make the lenses, they put them into a cheap frame so you can just pop them on your face. Myopic lenses, they have to be specific for you because there's different levels of myopia. And they come in like 0.25 diopter increments. All right. So there's a wide range. They have to be made specifically for you. Sometimes people need progressives or bifocals if you're over the age of 40 or 50. And so there's just so many different types. Sometimes people who are very nearsighted, they need a high index of refraction lenses to make them thinner lenses. So there's a lot of considerations when you're making a pair of glasses for someone with myopia. That's why it costs a lot more than just over-the-counter readers. All right, just the complexity of the material, of the refraction. They have to get specially made for you. When you're getting custom anything, particularly glasses, it's going to cost more. Let's do how about a few more here? I pulled a muscle in my neck. So if you see me on YouTube and I'm like rubbing my neck, it's because I don't know what happened to me. I slept funny. I'm almost 40. This is what happens. All right. Let's see. How about at Matthew McKinney 993. Hi, love your podcast. Would love for you to do one with an astronomer, such as Ed Ting. This is a good idea. And talk about dim settings, dark adaptation, presbyopia, and the similarities between telescopes and eyeballs. I think in astronomy, it's a good idea. It's a really good idea. Having an astronomer and an ophthalmologist, getting them in a room together and having them nerd out over focal distances and telescopes. And I love it. I love it. So I'm going to be on that. If you have any other suggestions, I'm going to look up Ed Ting and we'll see what we can do. Anybody has any other suggestions for astronomers? I'm all ears. Okay. Let's see a couple more. And by the way, I want to thank you guys for all the love you give these Knock Knock Eye episodes. Like clearly, like you guys are listening to them, watching them, and getting something out of them. And that's the whole point. Like I'm doing this because I want to impart a little bit of eyeball knowledge, as well as my own soapbox thoughts from time to time. All right, at RT Davis 2705, Dr. G, I've accommodated my disability since the 8th grade. Gone through glasses, contacts, and even considered LASIK up until my brother had a really bad experience with it. Now, closing in on 70, I see cataract surgery in my future, especially after a recent and unexplained retinal tear and repair work. I really appreciate your Knock Knock Eye videos and use of layman's down-to-earth language in your discussions. Oh, and the absolutely hilarious skits have me laughing out loud from time to time. Oh, thank you so much. And so I guess this is not so much of a question as a comment. I appreciate that. But the idea of a retinal tear is pertinent to what I'm going to be talking about here after the break. So let's actually put a pin in that one. There's one more comment. A lot of people, I did a couple episodes where I was railing against RFK. A lot of people agreed with me. That in chiropractors. Oh, someone said that they also took a paper MCAT. I said on a previous episode that I was the last paper MCAT that was administered, but I guess someone else did it. Are they still doing that? There's no way. There's no way they're still doing paper and pencil MCATs. I refuse to, and I'm not even going to look it up. I refuse to believe that. So sorry, whoever you are. Okay. You know what? Let's go ahead and take our last break, and let's talk a little bit about flashes, floaters, retinal tears. Hey, Kristen.
Yeah.
I know that you love when I talk about the cute little mites.
Mm-hmm.
Yeah, but I thought we could take a break from that. Is that okay with you?
That's fine.
Yeah, because I'd like to focus on the eyelid symptoms and disease that an overgrowth of Demodex causes.
Okay, I like that idea. No mite talk.
So Demodex blepharitis, it often gets misdiagnosed or just missed entirely because a lot of symptoms overlap with other eye conditions.
Okay, so what are the top symptoms that people should look out for?
Usually itching along the eyelid margins, swelling, irritation, redness.
That sounds like it could be allergies or lots of other things, too.
It could be a lot of things, but exactly. And the key is if your doctor spots crusties on the margin of the eyelid.
Mm-hmm. Technical term.
Well, we call them collarettes, but crusties is a good term. That tells you it's Demodex blepharitis right there.
Well, I really like that there's a clear sign to know for sure.
And once you're diagnosed, there's a prescription eye drop treatment available for this disease.
Ooh, that is good to know.
To learn about the common symptoms of Demodex blepharitis and more, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. All right. Well, I saw a patient. The reason I want to bring this up because I had last week in clinic was the week of retinal tears. It was crazy. I had like maybe four retinal tears that came into my clinic over the course of a week, which is a lot. It's a lot. So let's talk about it. So let's talk about flashes and floaters. This is a very common problem. Maybe a lot of you, I'm sure almost everybody has noticed a floater or will during the course of their life have floaters. So what do floaters represent? And so when I say floaters, people come in, they describe floaters in all different ways. Floaters are those really annoying things that get in your vision. They don't prevent you from being able to see 99% of the time. All right. There is a very small subset of patients that have severe, thick, dark floaters that really do interfere with your vision. Most of the time, though, they're just annoying as hell. They get in the way. You're kind of move your eye around. You're swatting at flies. Probably the most common story I hear is like, I thought there was something there. I thought that I had to clean something off. I thought there was a fly buzzing around me, and I was batting at it like a crazy person. And turns out it's just a floater. And so they can come in all different shapes and sizes: spots, dots, strands, spider webs, clouds, sheets. And it all just depends on what it looks like. And that's just kind of luck of the draw, honestly. And then flashes, in my mind, are a bit more sinister. They're a little bit more potentially serious because a flash of light means that something has stimulated your photoreceptors to cause you to see a light, especially if it's a light that's really actually not in your visual field, right? You're not actually looking at a light. There actually isn't a strobe light off to your side. So what's causing that? Well, it's stimulation of your photoreceptors. Why would that happen? Well, that happens when the vitreous, which is a vestigial structure, you don't have to have vitreous once you're born. The vitreous serves no purpose. But what it does is whenever you're in development in utero, the vitreous is full of blood vessels and basically nutrients that helps keep everything healthy and growing. But once you're born, by that point, the vitreous is just this jelly that doesn't have anything in it. but it holds the space in the eye. So it just fills the majority of this space inside your eye behind your lens. That's the vitreous. All right. It's a jelly consistency. And so when you're born, it sits there and it's firm. It's firmly attached to your retina, which is the wallpaper that lines the back of your eye. So you have vitreous jelly kind of just firmly attached to that wallpaper. What'll happen over the course of your life? Honestly, it starts early. When we think of the first time you ever noticed a floater, for some of you, I'm sure it was probably in your 20s. Throughout the course of your life slowly, that vitreous jelly, it degenerates. It basically it liquefies, it condenses, and it forms all these spots and dots and strands that are called floaters. They become opaque. They age. That's what it is. And it happens throughout your life. And what'll happen typically in your 50s and 60s is it'll degrade. That vitreous will degrade enough to where it reaches this critical point of no return where it collapses in on itself. And it just in a one fell swoop almost, or at least most of it, it'll just all of a sudden, it just detaches from your retina. That's what's called a vitreous detachment. It just degenerates enough to where it can't hold on to the retina any longer and it falls off the retina. That detachment process sometimes it stimulates the retina. It'll stimulate the photoreceptors because it's actually moving the retina with it. Right? It's like, imagine you're peeling a sticker off of the backing. That moves the backing. You're moving both things. And so that movement of the vitreous detaching, it'll stimulate those photoreceptors and give you a big flash of light. Now, the danger and the reason we get concerned about flashes is because that process, that vitreous detachment process, sometimes it's a little bit too sticky. And it'll actually, instead of detaching from the retina right away, it'll actually pull the retina with it and cause a tear in your retina. And if you have a torn retina, well, fluid that's in your eye can track underneath the retina and cause a detachment. It basically just detaches the retina from the underlying tissue. That's what we're trying to avoid. So when we tell people, oh, you had flashes of light, you should go in to see the eye doctor, that's why. Because when you have symptomatic flashes, the studies show that you have about a 10% chance that you have a retinal tear. 10% chance. That's pretty decent. Decent enough where I would want to go see an eye doctor. If I had a flash after recording this, I'd go and have my partner check me out. All right, because you don't want it, because a retinal tear could turn into a retinal detachment, which is a much bigger treatment. With a retinal tear, if we diagnose that, which I did today, all it takes is some laser to basically spot weld the retina around that tear to prevent fluid from being able to track in the tear and detach the retina. You're spot welding it. That fluid, it'll get to where you spot welded it and it can't propagate any further, right? So you're blocking that fluid from tracking in there. And so you're treating it. You're not repairing the actual tear. The tear is going to be there for the rest of that patient's life, but you're just preventing it from getting worse. You're preventing it from causing a detachment. Now, the good thing is when you have a retinal tear, typically these tears are in what we call the periphery of the retina. Usually it's in a place where it doesn't impart any vision problems, right? You would think that, oh my gosh, your retina is torn. You've torn the photoreceptors in that part of the retina. That's going to affect your ability to see. But usually it doesn't, because you only have a certain amount of retina that's responsible for your actual vision. All right, your central vision and your peripheral vision. You have some retina that has some photoreceptors, but it's not in a position, it's not actually responsible for any usable vision. All right. And that's often where the retinal tears are, because that's a weaker part of the retina. It's a thinner part of the retina. So it's more likely to tear. But If you have a detachment, well, that's when it starts to affect the vision and you start getting like a curtain coming over your vision. If you have the fluid track in the tear, detach the retina, well, what happens is if the retina detaches in a place where you have useful vision, let's say right in the center, then it's like you'll see it's like a shadow. What we call it a curtain that just comes over your vision, and you can't see anything through that. It's like someone's just taking away your vision. And that's what we always warn people about. If you notice a curtain where an area of your vision is grayed out or blacked out, that could be a retinal detachment. So it could be a lot of things, but one of the things is a retinal detachment. You got to get that checked out. Don't ignore that. So by spot welding the tear, we're preventing the retinal detachment from occurring. Sometimes the tear and the detachment all occur simultaneously. It's immediate. The tear is so large that there's no hope, right? The fluid tracks in there, detaches the retina. By the time we see the patient, even if it's like an hour after the tear, sometimes there's already a detachment. But we're trying to catch the people that, have a tear before it becomes a detachment. Now, our retina colleagues in ophthalmology are amazing, and they can fix retinal tears and they can fix retinal detachments. So if we do see a retinal detachment, that's okay. We'll fix it. It's just a little bit more involved than just doing a laser. Sometimes you have to go to the operating room. So it's just a little bit more involved, but that's okay. We'll fix it for you. All right. One of the most amazing things we can do in ophthalmology, and I say we, even though I'm not the one that would do it, my partner does, is reattaching a detached retina. I think it's one of the coolest things you can do. All right. Requires specialty training. You have to do 2 years of surgical training just to learn how to do that. And so trust the experts, I'll say, especially in ophthalmology. So anyway, that's your primer on retinal tears, retinal detachments, flashes, floaters, and I think that's all I got for you. We'll call it a day. All right. Thanks for listening thanks for listening and watching to Knock Knock Eye. I'm your host, Will Flannery, also known as Dr. Glock. Thanks to my executive producers, Aaron Courtney, Rob Dolman, and Shanti Brick. Editor and engineers, Asa Portiz. Our music is by Omer Benzvi. Never forget, leave a comment on our YouTube channel at Glock. It is steadily growing. It's just a podcast channel, so it's new. It's been around for like a year now, but we're steadily, more and more people are finding it. So tell your friends, leave a comment. I always, right before I record, I look at last week's comments. So chances are I read your comment. I just can't address all of them. So let me know if you have any topics, eyeball topics, questions you have, anything. Why do I sneeze when I look at an eye? Why do I sneeze when I look at a light? Like stuff like that. Like I'm happy to answer anything eyeball related or otherwise. All right. So leave a comment at Glock and Fleckens. We'll see you next time, everyone. Take care.
Knock, knock, goodbye.
Hey, Will,
Hey, what's up?
I've been thinking the U.S. healthcare system, it needs some improvement.
Yeah, there's room for improvement. For
Yeah,
sure.
it's a confusing, scary place for everybody involved.
Absolutely.
Physicians, families, patients, everybody.
Everybody. And I've experienced it from both sides, right? I'm a physician. I've also been a patient. So I wanted to use my platform to give people practical education, really the only way that I know how, by making jokes. So Dr. Glockenflecken's really fun and super uplifting guide to American healthcare is out, and it's a free resource that includes all my videos from the 30 Days of Healthcare series, alongside deeper explanations, also reliable facts, emphasis on reliable.
Yes.
All right. Figures, numbers, insights into how each of us can fight for a more humane, better healthcare system. Also, it has jokes.
Did you mention the jokes?
I did. Jokes.
Okay.
Yes, definitely jokes.
Well, this guide is great for anyone looking to learn more about U.S. healthcare, but especially if you are experiencing it from the clinician side for the first time.
That's right.
Really hope you'll check it out.
Get the free guide sent straight to your inbox by signing up for our mailing list, glockenflecken.com/healthcare. Enjoy. Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.